Hello, dear Derek. Thank you very much for your amazing lecture. Also, thank you very much for your kind words regarding my father. Yeah, it's a pleasure to have you in this project, and also I want to this I will post this audio during the episode. So I just want to once again to thank you more in public this your contribution to this project, and hope to see you soon to discuss more about orthodontics and airways, etc. So once again, thank you very much, and see you soon.
Okay, good morning from Melbourne in Australia, where it is Sunday. And I'd like to take this opportunity to pay my respects to a great man in our field, Dr. Pablo Echarri, who motivated me to do further research when I spent a lot of time with him in Barcelona, and led to finally my PhD study, where I looked at the link between malocclusions and sleep apnea. This has recently been published in the Journal of Craniofacial Research, and if anyone would like a copy of my research and of that paper, they could just please send an email to this email, info@mahony.com. So this photo is with myself and Dr. Christian Gimeno. And Dr. Gimeno was influential when I was at Stanford to give me a thorough understanding of what pediatric sleep apnea is, and specifically the difference between that and sleep disordered breathing. Now, many people would be wondering, why would a orthodontist be interested in this topic? And the purpose of my research was to link the percentage of children who were referred to my practice for orthodontics, class 2, class 3, open bite, cross bite, deep bite, etc., and to assess whether those children also had these underlying conditions of poor sleep, snoring, sleep apnea, etc., etc. So I think this slide is a good summary of what I'm going to discuss in the next hour. And it's to tell people that malocclusion, which you can see here as crowding, is connected to a number of other things. And with children, and in this study, the children were limited between the ages of 7 and 9. The concept of looking at bruxism, snoring, mouth breathing, their inability to concentrate, delayed learning, all of these were related. So the first question I ask any dentist or orthodontist who's listening to this lecture, is there a link between malocclusion and sleep disordered breathing? And in my research, which looked at a large number of patients, it would be 90% correlation. So why is this, and how can we diagnose it? More importantly, what can we do to help treat it? So this is a lecture that Dr. Juan Quinteros gave at a Florida meeting, and he talked about his journey as an orthodontist. And I would link this very much with my journey, and also people hopefully who are listening, whether you're a new graduate, a student, or been in the field for many years. And that is the ability for us to look deeper than what we were taught in orthodontic school. If I looked at the lateral ceph in orthodontic school, I was looking at figures by Tweed, APO line, all the things from tooth movement. Now we give a deeper dive, and we have the ability to use CBCT, and we can look at what is circled here. Large turbinates, large adenoids, reduced airway. So when you look at his journey, this is Dr. Juan Contreras, he looks at what we dealt with, which was the worst case scenario. The child who wasn't treated in mixed dentition, who now is a young adult and has impacted teeth, severe class 2 jaw problem that may require orthodontic surgery, and definitely dental crowding. So he works backwards and he says, well, what causes crowding? Not what we have been taught, possibly the link between large teeth and small jaws that might be genetic. In actual fact, there is a link between not large teeth, but the reduction of the palate. So a constricted maxilla is caused by a number of factors, which I'm going to discuss. One is mouth breathing, the other is poor tongue posture. And if you look at these factors, they all stem back to one thing, which is nasal obstruction. So Goumeno was very big on assessing sleep, but also saying proper sleep came from proper nasal breathing. And we as orthodontists have a great role to be able to work backwards to the cause of the problem, which is the nasal obstruction, and try and change that by widening the palate, changing the tongue posture, so we don't get as much constriction of the maxilla and we don't get as much crowding, and therefore we don't have to extract as many teeth. So that's what I'd like to cover today. So, what are some reliable outcomes, and what is some possible prevention of sleep disordered breathing and sleep apnea in children? So I love to reference people who I've learned from, and I would certainly put right up in the top Dr. Audrey Yoon. Audrey is an amazing individual. She is a pediatric dentist who then became an orthodontist and then went further to do her research and training in the field of sleep medicine. So she published in 2023 this roadmap of craniofacial growth modification. And I think if you're going to read one paper, hopefully it'll be my research, but if you want a clinical guide on what my research is saying, this is your paper. So many orthodontists, including myself, when I was in training, we really didn't treat any child in mixed dentition. By the time the children in the hospital came off the waiting list, they were already 13, 14, 15. So we weren't able to really look at doing any craniofacial growth modification. And we certainly had not one lecture in assessing mouth breathing and sleep. So what happens now, we have a multidisciplinary management of sleep disordered breathing in children, and there's more and more application of orthodontics in this field. So obviously I'm going to talk about what she discusses, which is a team-based approach. We cannot diagnose the problem on our own. We normally have to work with a primary care physician to do that, but we can certainly help guide that diagnosis. And more importantly, we, via dentofacial intervention, at the right target time, the right growth pattern, we can influence the future direction of that child's development, both facially, dentally, and academically. So what Audrey's done here, she's broken up the age groups into preschool, which would be 0 to 5, and then mixed 6 to 9. And that's really where my research took place. So I would love to do another research project when I looked at, where I will look now at primary dentition or maybe late mixed dentition, but ultimately my research only dealt with one area, which is the area in blue, and the concept that Audrey is saying here. If you look at the age group and then you look at what we can do, even from 0 to 5, we can have an influence on that child's breathing and their posture. In my category, I'm going to talk a lot about the maxilla being deficient, narrow, retrognathic, and how we can influence that by expansion and reversible headgear, to bring the maxilla in its correct spatial position for airway, and then we know where the mandible should match. So we can do semi-rapid expansion. We find that tends to unlock the mandibular position. And if need be, we can also catch up with some functional appliances on the mandible, but I tend to do that in the green zone, in the late mixed dentition. At any stage, you can see when it comes to nose and throat, enlarged tonsils peak at age 3 to 7. Adenoids peak at age 10. So if we're going to get involved in changing the kids' breathing, we do work with nose and throat doctors. And at any stage, we should also work with myofunctional therapy, which is improvement of nasal breathing, proper tongue posture, chewing, swallowing, addressing these parafunctions. So I will talk today about the early mixed dentition, but please read this paper because then you can learn what you could do in this multidisciplinary field and at what age you would help these children that have sleep-disordered breathing problems. But in my research, after we diagnosed the child that had the problem, we obviously did an overnight sleep study, and then I did various treatment modalities, nose and throat only, nose and throat with dentofacial orthopedics, myofunctional therapy only, myofunctional therapy with dentofacial orthopedics. And what I found was the best outcome was the multidisciplinary role, which was I used this to expand, release, retrain. So a lot of the children had nose and throat issues. I widened the palate. We made sure that the myofunctional therapist helped the child put the tongue on the palate and release the tongue if needed. And then we simply monitored that child develop their permanent dentition, what we call the orange zone. And the new paper that I'm working on is what percentage of children who had the proper care, which was ear, nose, and throat work, orthopedics to develop the jaw, and then myofunctional therapy, what percentage of children actually needed fixed orthodontics? And secondly, those who needed orthodontics, what percentage of those needed extractions? And although I haven't published that data as yet, I can tell you it's certainly showing that the better intervention reduced the need for major orthodontics later in life. And even if they needed orthodontics or not, they certainly already had a good looking face and a good airway. So question number one, for those orthodontists who may not have done much in this field, is sleep-disordered breathing common in children? I would say absolutely yes. And here's some interesting facts to think about. If you have a patient a child who've identified snoring, they're 4 times more likely to end up in the bottom 25% of their class. If they have sleep apnea, they're 9 times more likely to be in the bottom 10% of their class. So you can see the link between their cognitive development, their academic performance, and their airway. And the big thing in Australia, at least, is the number of children incorrectly diagnosed with ADHD and automatically put on stimulant medication. In one of the studies, I'll quote, 48% of patients who were already on stimulant medication for ADHD, who then had a sleep study, were found that they didn't truly have ADHD, but what they did have is sleep-disordered breathing. So that's obviously a link in the symptoms are very similar, but the diagnosis is very specific. And I would say if you have ADHD patients, you should really be assessing their tonsils, finding out if they snore, and organising an ear, nose, and throat consult. And there was a large number of patients in my sample that came to me again for malocclusions, but when I looked further, were already on medication for ADHD. So some of the common histories, medical histories you see with these children, they grind their teeth, they snore, they're restless sleepers, they're hyperactive during the day. They maybe have nocturnal enuresis. They're certainly not paying attention at school. And if you look at the sleep studies, a lot of these had what's called oxygen desats. But what they also had, believe it or not, which I'm bringing to the table in red, a lot of them had quite severe malocclusions. In this second paper, that Audrey has published in the American College of Prosthodontists. She's looking in conjunction with Dr. Sujun Kim from the University of Seoul in Korea. She was looking at what type of malocclusion or craniofacial type would be found common in these children. And in this paper, which was a comprehensive review, they were looking at typical class 2 hypodivergent growth patterns. Also, class 3 underdeveloped maxillas. All of these reduce the nasal cavity, the nasopharyngeal airway volumes. So, you know, there's a link that what we can do as an orthodontist to improve the transverse maxillary constriction. You know, these kids have a high deep palatal vault, which is a significant risk factor. And additionally, that nasal obstruction and low tongue posture with or without a short lingual frenum is also identified as a craniofacial risk factor. So look at the conclusion here. Early diagnosis and intervention are critical in managing pediatric sleep disordered breathing. And we as dentists and orthodontists, through screening and early treatment, can significantly influence the child's craniofacial growth and hence their health outcomes. And I think this is a real wake-up call for our profession. And from that paper, you can see that the pathophysiological factors are anatomical, where we come in. So class 2 jaws that have narrow maxillas, retrognathic mandibles, long faces, mid-face deficient class 3s. So in the soft tissue abnormalities, we're talking about the ear, nose, and throat stuff, such as T's and A's. Then you have the non-anatomical factors, which is the inflammation, the hypertonia, and neuromotor dysfunction. But the combination of that is what leads to this problem. And remember, obstructive sleep disordered breathing is a chronic disease, and it has multiple risk factors. So therefore, there's not one treatment that will totally cure. And this is another thing I'd like to point out, that if you have a child who has this problem and you refer them to an ear, nose, and throat doctor, and the ear, nose, and throat doctor removes their tonsils and adenoids, that does not mean they're going to have a 100% fix. In my study, those children who had a PSG before seeing the ear, nose, and throat doctor and a PSG after, they showed on average a 50% reduction in their apnea scores. And when you follow those kids long term, they still have a high recurrence rate. So I think what I'm saying is what matters the most is getting these children that multidisciplinary model, and being more research should be in the field of phenotyping, you know, because if we're going to do precision medicine, we need to be able to see that. And as Audrey has shown, and I've shown in my paper in the Journal of Craniofacial Research, there is a facial type, which I, with Kevin Boyd, have termed class 4. What is a class 4? The maxilla and the mandible are retrognathic, and the patient has increased vertical facial proportions. That craniofacial type we found had the 100% correlation with sleep disordered breathing and sleep apnea. So what was I taught when I was at Stanford in treating these children? Well, in the short term, they need to be put on CPAP. But in the long term, CPAP is going to affect their forward growth, affect their craniofacial development. So although you're fixing one problem, you're actually creating another one. So again, from that paper, if we look at the influence of sleep disordered breathing on orofacial growth, you can see in the middle is mouth breathing. What causes mouth breathing? A number of things. Septal deviation, large inferior turbinates, large adenoids, large tonsils. Then you look at, well, chicken or egg. Does that mouth breathing, which gives a extended head posture and a lowered mandibular posture, then affect the craniofacial growth? the cycle on the right, the mouth breathing gives the lower tongue posture, and that's what's leading to constricted maxillary arch form, which also affects orofacial growth. So you can see how on the left-hand side, we're going to work with our ear, nose, and throat doctor. On the right-hand side, we are the gatekeepers of the airway, because we're the people who can change that constricted maxillary arch form, change the mandibular posture, change the tongue position. So the key elements here are proper diagnosis and then working with a team. In my craniofacial team, ear, nose, and throat doctor, very important. Myofunctional therapist, very important. My team, essential for changing the dimensions of the palate and the position of the upper and lower jaws. So when we talk about what is sleep disordered breathing, it's now defined as a syndrome in children, syndrome of upper airway dysfunction during sleep. So it's characterized by snoring and or increased respiratory effort. And that's because that upper airway resistance is increased and the pharyngeal collapsibility is increased. So if a child is snoring more than 3 nights a week, even without apnea, and they have frequent arousals, or they have oxygen desats, I mean, they are in this clinical entity. And if you don't treat that, then as that child matures, as the problem continues, you'll see that they lead towards the obstructive sleep apnea syndrome, which is the recurrent events of partial or complete airway obstruction. So it's like anything. We test our children for their eyesight. We test our children for hearing. Why aren't we testing our children for their airway and their sleep? And I think orthodontists spend more time with a child and a parent than any other member of the medical dental team. We look in the mouth, we look at the x-rays, and there's so many factors that we can pick up to help nip this problem in the bud. So if you look at these two patients, you can see the young girl on the left has a very narrow maxilla and a very retinathic mandible. And she's in that age group 7 to 9, which is the perfect age group when you look at Frankie Bacchetti's research in being able to modify and influence craniofacial growth to widen her palate and get her maxilla in a forward position. The chap on the right is more the orthodontic age. So this chap is 13 and the damage is already done. So he's been a mouth breather all his life. And now, as a classic orthodontist, if I take off my craniofacial hat, what I'm seeing here is crowded teeth. And what I'd be offering this child potentially is 4 bicuspid extractions, which will straighten his teeth or make room to straighten his teeth, but it certainly will not influence in any way his breathing because I'm not getting to the root cause of the problem, which is his narrow jaw. So if I was now offer this chap ideal treatment, I would do MSC off the maxilla. I'd line up the teeth and I'd work with my maxillofacial surgeon to do counterclockwise bimaxillary osteotomy, where both the maxilla and the mandible would be rotated forward and upward. And then what am I doing? I'm changing the lower face height. I'm making the face look better. I'm opening up the airway. But what a big procedure to go through when I could have nipped that kid in the bud between 7 and 9. How would I nip it in the bud 7 and 9? I would have sent him to the ear, nose, and throat doctor, change his breathing from mouth breathing to nasal breathing, widen his palate at the appropriate age before the canines had erupted, and then with myofunctional therapy, encourage what we call forward growth off the jaw. So in my PhD research, and again, for Friends of Pablo, there's not many people in my life that I would credit with what I'm crediting Pablo. Pablo was an amazing host. Those who knew him knew he loved fine wine, good food, and he was really passionate about education. And all my visits over the 30 years that I knew him to Spain were always met with great hospitality, passion for learning. His Athena Institute, which is his legacy now taken over by his son, will still continue to be a landmark for his passion. And his passion and my interaction with him was say, Derek, you're busy in clinical practice, but you need to document all these cases and publish and publish and publish. And if it was for him, I don't think I would have really got off my backside and done this research. So thank you again, Pablo. Now, in my PhD research, I looked at a number of factors, right? The first thing I looked at was the relationship between malocclusion and sleep disorder breathing, high relationship, greater than 90%. Then I looked at what treatment outcomes, either on their own or combined, had the best end results, right? So I included, obviously, orthodontics in the treatment plans for these children. I worked with ear, nose, and throat doctors doing various procedures. And my ear, nose, and throat doctors are very highly trained. I'm lucky to work with them. They also did the lip and tongue tie if needed, and we put that in the category of ear, nose, and throat intervention. So the most favorable dentofacial orthopedic outcomes for these children were after the airway was improved, and the stability of the children was the best in those who work with a oral myologist. So there's a lot of things that came out of this research pointing to that. So, what are some developmental issues if we don't treat early this condition? So certainly in US stats, it's estimated 1 in 4 children between the ages of 2 and 8 has pediatric sleep disordered breathing, and the large percentage remain undiagnosed. And that's where we come in. We are taking records for these kids. We should be, at the bare minimum, in our medical history, giving a pediatric sleep questionnaire to the parents to fill out. I like particularly the BEARS questionnaire, and I mentioned that in my PhD research. These pauses in breathing for these children are typically much shorter and lighter than adults with sleep apnea. So if an adult snores loudly and makes choking noises, a child may simply stop breathing momentarily and then wake up. Both the sleep apnea and the sleep disordered breathing, lead to sleep deprivation and a wealth of other health issues if left untreated. So they have symptoms of restlessness, bedwetting. The parents notice that their kids snore. During the day, the children may seem tired and inattentive, but you also have the daytime symptoms that include hyperactivity and mood swings, right? So we find that when we look a bit more than our cephalometric norms and we look into the mouth, we see enlarged tonsils. When we look at our CBCT, we see inflamed inferior turbinates, large adenoids. So obesity is a big thing now in the Western world, and there's a high correlation between obesity and sleep apnea, particularly in the children. So because pediatric sleep apnea starts at such an early age, it can stunt growth and lead to a number of developmental issues. And over time, if that child is not getting enough quality of sleep and he doesn't get enough oxygen due to good quality sleep, you are going to have development problems in his brain and his body, and of course, his jaws and his teeth, right? The child's more likely to be diagnosed later in life with things such as ADHD, childhood obesity, and patients who've grown up with untreated chronic sleep apnea are also more likely to have learning disabilities. You saw that in my first slide, the percentage of children who snore at the bottom of the class. So I think pediatric sleep physician is important in the diagnosis, but in some countries and some locations, it's not always possible to have a pure hospital-based study. So if you look at the research and some of the papers I've published, that I've referenced in my publications, we talk about the ability of measuring oxygen desat in these children by a simple pulse oximeter which won't replace the PSG, but that with a pediatric sleep questionnaire are both high correlated factors that the child has a problem. And remember, these children, because of their age, that they aren't able to identify the problem on their own. So I think it's crucial for us to educate their parents to pay close attention to their children's sleep habits and their daytime behavior. So this young lady is also what we call class 4. Class 4 means, as I said, she has a maxilla that is retrognathic and a mandible that is also retrognathic. So she's class 2, but she's class 2 bimaxillary retrusive. On top of that, she has an increased lower face height. Now, her concern is that she has sleep apnea and she can't cope with a CPAP machine. So she has undergone a counterclockwise bimaxillary advancement osteotomy, and look at her face. Does it look better? Of course it does. So what I'm trying to show you here is a balanced face, a good-looking face, is a good airway. And you don't have to wait until this girl is 25 to then do a major two-jaw surgery. You could treat this at 7 to 9 with dentofacial orthopedics and get as good an outcome. John Mew, over many years of collecting data, summarized that facial growth can improve from being downward and backward to being upwards and forwards if you can improve the posture. And his hypothesis in his premise is an improvement in oral posture will improve facial growth. And I totally agree with that. Now, how you achieve that? Many ways. And this is not about you have to use this appliance or this bracket. Whatever you can do to develop that palate so that there's space for the tongue, and then work with the perverted muscle activity to do what this girl has had done at the appropriate age. So again, what do you see before and after? You see a good-looking face, you see a good airway. So you can do it the hard way, or you can do it the easier way. It's all about timing. And I think the most important role you will have as an orthodontist is not to straighten the teeth. And I keep saying this, that if I was to improve Krista's front teeth by some partial bracketing, some 2x4, and I didn't address her breathing, and I didn't address her sleep apnea, what am I doing? It's like rearranging the deck chairs on the Titanic. And that's why I think there's a greater calling in our profession to look more deeply at these child's problems. This is one of my students, Kurt, and he has done my 3-year program in dentofacial orthopedics and orthodontics, where I really push heavily the appropriate treatment, the appropriate diagnosis. And, he had no idea before doing my course that bruxism had anything to do with airway. We were always taught in dental school, and he thought bruxism was just related to stress. And, when you're talking about a child that he describes here, a 6-year-old, he automatically realized that child had large tonsils, had poor sleep. And so he sent them to an ear, nose, and throat doctor. He then monitored that child at his normal 6-monthly appointments. And he noticed that the behavior had changed, the palate had changed, and the mum is ecstatic, right? So he's thanking here my colleague, David McIntosh, who's very influential in this field, one of my co-speakers in my 3-year program, and has a lot of stuff on social media on what an ear, nose, and throat doctor can do to help the child. I really get a big kick out of one of my students helping another patient because of my education. And that's why, and that's why, again, I link back to Pablo and how he was passionate about education to help those in need. So this is one of the first of my papers from the research. In this paper, I had reviewed the data of Sten Linder Aronson in his landmark study in Sweden when I was an invited researcher in the Karolinska Institute. We looked at the face height in children who had mouth breathing habits, in this case, specifically large adenoids, and then what happened when we changed their mode of breathing, what happened to their dental development and their face height. So the term I'd like to coin here is the term adenoid facies, a common medical term used to describe facial characteristics of a mouth-breathing child. Now, what I'm saying here, even though this paper specifically look at adenoids, there's a number of causes of nasal obstruction. It doesn't just have to be adenoids. But these children have one common thing. They have a long anterior face height and they have a retrusive mandible. What Audrey was talking about from her review paper, what I showed in my paper in Journal of Craniofacial Research. So habitual mouth breathing alters the facial and muscular force vectors on the developing craniofacial skeleton, and it then leads to long-term changes in craniofacial morphology. So as a consequence, these children develop retrognathia and compromised horizontal growth. So what we want to do is get that compromised horizontal growth, as you can see on the left, into favorable forward growth. And that's really what it's all about. But you can't just do it with the ear, nose, and throat doctor. You can't just do it by widening the palate. You need to work with a team, and the myofunctional therapy is very, very important. Now, is this new? Well, for many of you, and for me, it certainly was when I was first in Darrington to look at anything to do with airway, because remember, I did 3 years of orthodontic training at a famous institute in London. And during those 2 years, I certainly learned how to move teeth well, but I wasn't exposed to looking at a child's airway, their posture, their breathing, until I had spent time in Sweden. Now, I had to do an extensive literature review for my PhD. And if you look back at what was published, the Dental Cosmos is the precursor of JADA, Journal of the American Dental Association. This paper in 1909 had an article, Habitual Mouth Breathing and Consequent Malocclusion of the Teeth, Then there was a section on early treatment of malocclusion and also early treatment of nasal obstruction, and it's linked to dentistry. So I think we nowadays are working more and more in the field of AI. And certainly one of my projects is to develop an app which is free for parents and clinicians to use, where they can look at a child's craniofacial morphology at the right age and almost predict that this child will have sleep-disordered breathing problems, right? So we work year in year more closely with our medical profession, but I think there's no better example of this to improve the health of our children and to prevent them from more serious health problems than that close alliance between ear, nose, and throat and orthodontia. So in this paper, and again, 1908, they're talking about what are the signs of mouth breathing. And the earliest symptoms, they're saying, manifest during the sleeping hours. The chin recedes, the roof of the mouth is narrow, the dental arches become constricted, and the teeth become crowded. So, the classic is, look at the last line. Teachers will accuse the children of being inattentive at school. I mean, there is your ADHD that we're currently over-medicating, mentioned back in 1908. Another paper here, which is just entitled Fallacies in Orthodontia. And in this paper, they're saying, with many malocclusions, advised to wait until the teeth are fully erupted. In other words, wait and see what nature will do. And why wait for the malocclusion to become more complicated when those facial bones are already deformed. And look at in blue, and brain development is retarded. Now remember, my research was 7 to 9, but now that I understand more about oxygenation to the brain, by 7, that brain development is already finished. The growth of the brain is maximum in age 4. So there's this whole new field of, do we expand earlier? Do we change tongue postures even earlier? Not for teeth, but to help the sleep and the oxygenation to the brain. So they're talking here back in 1908, could we be expanding in the deciduous arches? And this is, another lecture that I've given where I talk about why I now, based on ear, nose, and throat referral, based on poor sleep, based on the correct diagnosis of sleep-disordered breathing, I do expand on primary molars to drop that palate down. And that paper was presented to the Pennsylvania State Dental Society at its annual meeting in Pittsburgh, and look at the year 1909. So it's kind of incredible that here we are over 100 years later still debating this topic. And I thank Kevin Boyd this element of challenging my thought process of why, Derek, are you waiting 7 to 9? Yes, your research showed a great change and blah, blah, blah. But, if the kid has airway problems and sleep problems, you're focusing too much on what can be avoiding orthodontics in mixed dentition. What about avoiding their poor performance at school, et cetera, right? So he's the one who alerted me to look deeper into literature and see really how this had been already published so many years ahead of time. So highlighting here, general characteristic picture in a case suffering from nasal obstruction and prolonged mouth breathing is that you have a high V-shaped palate and you have irregular teeth. Early diagnosis and treatment should be done for the common good of humanity, and the specialties of dentistry and neurology may continue to have that close correlation that's been established. So again, this took me 15 years, not because I was lazy, but because I was working full-time still trying to do this on a part-time basis. And I did many trips back and forth from Sydney to Barcelona, hence, again, my close involvement with Pablo. And this thesis, treatment of OSA in children, we measured everything that an orthodontist normally measures, but we added one more thing, and that was the sleep study, the PSG. So the sample of my group, 3,672 children between the ages of 7 and 9. We first looked at what percentage had a malocclusion. We looked at those who suffer from signs and symptoms of sleep-disordered breathing, not just OSA. And the second aspect of the study, which I'm now publishing, was to evaluate what combination of treatments had the best effect in reducing this problem. And to me, as I said, and I'll say it again, it was a combination of fixing the airway first, changing the jaw size and position second, and then maintaining that change with orofacial myology. So, I mean, there's so many things that I measured, and around about the same time I was completing this research, I completed a course at Harvard Medical School on the use of AI and certain softwares. And it's amazing how laboriously my 30 years ago, when I was in Karolinska Institute in the middle of winter in Sweden, sitting down and hand tracing all these cephalometric radiographs. Nowadays, there's so many things that we can scan and extrapolate with new software. And one of the things is the hyoid bone. So as an orthodontist, you should really be measuring from the tip of your hyoid bone to your mandibular plane, and realizing the longer that distance is, the more this child is going to have that high angle growth pattern and more risk of sleep apnea. Everyone keeps talking about the transverse width, which is, obviously an important landmark, but what's even more important for breathing is the vertical height. And the vertical height is directly influencing nasal airflow because it is the roof of the palate. We then measured the upper and lower airway. We did so many measurements that's what took so long for me to finally publish, because my supervisor at the time, Pepe von Durenarx, was wanting to add more and more data every time to the sample. And to help me with all the stats, I'd like to pay credit to my good friend, Professor Maria Villa, who's now retired. She was from University of Barcelona in Rome. And she was able to help me to look and identify certain factors that we were then correlated. And, as I said, this is a multifactorial problem. So I don't want you to think you as an orthodontist are going to be the only person to treat this. There's a number of factors involved here, including weight reduction, including allergy assessment and treatment. So, when you work in a team to be able to change the airway, you see the great change in the craniofacial jaw structure. So again, this spectrum, whether it's snoring, mouth breathing, up airway resistance, which means the kid finds it has to put more effort to breathe, particularly at night, or the worst one where they actually stop breathing or reduce their airflow. All of these stem from narrow airways, which we can improve. They also have a reduced neuromuscular tone and increased collapsibility. That's where your oral myologist comes in. So, these conditions, which cause fragmented, unrestorative sleep, are linked to increased health risks. And one of those links is the malocclusion. So it wasn't just me who has identified this. You can see a paper published in American Journal of Orthodontics in 2017, where they looked at upper airway factors in class 2 and class 3 children. They showed that the mid-face deficient class 3s and the high angle class 2s in their mean age group here, which is about 9, definitely had a relationship between the nasal resistance and the craniofacial form. So form does follow function, function follows form, Melvin Moss revisited. So I guess one of the things that people couldn't quite fathom is why I used the Sassoon style analysis. I used that because it was very easy then to identify the discrepancy in the jaws. I wasn't looking at just the teeth. In fact, all the kids in my study, none of them had fixed braces, partial braces, etc. All of them were purely treated with dentofacial orthopedics, expanders. What type of jaw pattern was the most common in these children. And it was what we see here on the bottom right. The ones that had minimal airway problems were those who were biskeletal protrusive, so maxillary mandible ahead of where they should have been. Those who had the highest problems were biskeletal retrusive. So certainly jaws position plays a role in that. And then we added to that jaw position, of course, the vertical dimension. So if you were biskeletal retrusive and long face, that gave you a higher chance of the apnea. Another paper as part of my literature review, again from Japan, and they're looking at the nasal obstruction type, the adenoid type, and the tonsillar type to see that their skeletal features were very much linked to the type of obstruction they had. And if this nasopharyngeal obstruction, which we see in childhood, continues, it is going to affect maxillofacial growth. So, again, so much in the literature. But as far as working with medical people, they don't even look at malocclusion. They don't even offer the parents a glimmer of preventive hope. They are just saying, right, well, your child has a sleep problem, here's a CPAP, and that child will never come off that CPAP. In this paper, and this is something Christian Goodman was very passionate about, he said that CPAP is necessary in the short term to get oxygen to the brain, but you don't continue using it long term. In this paper, a 15-year-old boy who was diagnosed with sleep apnea when he was 5 and had nasal continuous positive airway pressure from 5 to 15, he developed classic mid-face hyperplasia. And you can see that although you are treating one problem, you're creating another one. And look at the face in B. That is a mid-face deficient jaw. To treat this, maxillary expansion, reversible face mask, which is one of the strategies we use for the malocclusion types that were referred to me with what we call class 3A. Class 3A, as you can see here on the top right, was where the mandible is normal, but the maxilla is retronating. Still a high precursor for sleep disordered breathing and obstructive sleep apnea. But rather than just put the child on CPAP, the proper treatment is expand and protract. So if you look at the child in the photograph C and you compare it to B, what's really happened? Again, an improvement in the facial profile. And I mean, we see this in the animal kingdom. If you speak to a vet, my uncle is a very talented vet, and he's the first one who says, dogs with mid-face deficiency, your British bulldogs, your pugs, they all die of sleep apnea and they have a much shorter lifespan. So, if you want to talk about comorbidities and you look at studies from the US, untreated sleep apnea in adults can, increase the likelihood of them dying 10 years earlier than someone who doesn't have sleep apnea. So it's important we nip this in the bud. Part of my training at University of Sydney in the field of sleep medicine was through Colin Sullivan. And Colin Sullivan invented the CPAP device, which we've just shown, over 40 years ago. And he developed it for adults. And then as he was retiring, and even Christian Gumner, as he was retiring, they both came back and said, listen, we could do a lot more to prevent the need for this. So in quote unquote from Colin Sullivan, the developer of the CPAP machine from University of Sydney in Australia, I spent a lot of my career looking at pediatric sleep apnea and sleep disordered breathing. And I think that if you intervene early and identify these kids who have the risk factors, you have the highest chance of preventing it. And there's no doubt the size and shape of the upper airway is important. So here he is saying orthodontic procedures can actually be very effective. And I think if we can identify earlier, we have a chance of preventing it. So, the big names in the field, Colin Sullivan, Christian Gumino, are all saying, yes, orthodontic work is good for prevention. So why is our orthodontic profession not seeing this? It's kind of frustrating for me. And I know Pablo did fantastic work in this field and was teaching early interventive orthopedic treatment. Another paper here, Journal of Clinical Sleep Medicine, where they looked at mid-face and dental changes associated with a CPAP in children who had obstructive sleep apnea. And again, cephalometric findings indicate a greater need for collaboration between sleep medicine physicians and orthodontists to monitor that mid-facial growth during the CPAP treatment. So, when someone's put on CPAP, they should also be referred to an orthodontist to look at their craniofacial form. And that's an important aspect of what we're saying. We as orthodontists now also, most of the orthodontic programs, certainly I have 15 private clinics here in Sydney, in Australia. And every one of those clinics has its own CBCT machine. And again, I'm not saying CBCT is the only diagnosis, but it certainly helps me to look at the bigger picture. So in this paper, which was a 3-dimensional assessment of pharyngeal airway in nasal and mouth breathing children, what did they find? From the CBCT evaluation, pharyngeal airway dimensions were significantly greater in a nasal breather than a mouth breather. So nowadays, rather than me look at what I was taught to look at, which is interincisal angle, molar class 1, 2, 3, lower incisor to APO, all the dental stuff. I now look more deeply in the nasal cavity. The nasopharynx is where we'll have our adenoids behind the palate, what we call the velopharyngeal area. That can be constricted in those mid-face deficient or maxillary retrusive patients. Then we look at the oropharynx, which every dentist should be able to identify, Malaparte scores, Friedman classification of the tonsils, et cetera, et cetera. So getting back to the treatment that we did for these children, we took records because they were referred to me for orthodontic care. But part of their diagnosis also included a overnight sleep study and a Bears questionnaire. So after they had ear, nose, and throat work done, whether it was just nasal spray or full T's and A's removal or lip and tongue tie release, they then had a follow-up PSG. I then started my orthodontic intervention, whatever that was required. It could have been maxillary expansion only. It could have been maxillary expansion and protraction. It could have been mandibular translation, and then they all ended up with what's called a phase 1 retainer. And the phase 1 retainer for me was something that allowed the teeth to still develop because these kids were transiting from mixed dentition to permanent dentition. But during that retainer phase, we were using a oral screen, what we call a myo brace. And again, it didn't really matter what brand you were using, but any form of myofunctional appliance in conjunction with myofunctional therapy. And then we did another sleep study. So sleep study as a baseline, sleep study after ear, nose, and throat, sleep study after my orthopedics, and finally a sleep study with the benefit of myofunctional therapy. And now these children are coming in permanent dentition, and those who are still willing to come back for their reviews, I'm now looking at what percentage of these kids who had this treatment protocol actually needed full orthodontic care, and how many of those needed orthodontic extractions of premolars. And I can tell you by just looking at the data that the percentage who needed orthodontic treatment was very low. So again, if you want to talk about true preventive orthodontics, is this the future? But whether you talk about straight teeth or not, I think that's an orthodontic argument. What about the child's performance at school? That's an even bigger picture. So this is the Bears questionnaire. And any of these papers or any of these questionnaires that you might want for anyone listening, I've given my email at the beginning of this presentation. Feel free to contact me. I'm very passionate about this. And, for Friends of Pablo, I'm happy to help you in any way I can. So we did a Bears questionnaire for all our parents. And of course, the parent has to fill this out. My ear, nose, and throat doctor, nasal endoscope evaluation. Also, they were happy that I provided them CBCTs. They then organized the sleep studies. Where I came in is if I had maxillary transverse hyperplasia or maxillary sagittal hyperplasia or mandibular hyperplasia, or the combination, which was the most common in the severe apnea cases, which was both maxillary and mandibular hyperplasia. So again, I'll credit Kevin Boyd for this classification, which I love, right? What is a class 4 malocclusion? A class 4 malocclusion inherits the retrognathia of the class 3 maxilla and the retrognathia of the class 2 mandible. And if you add increased vertical dimension to that, that's what you're talking about. Now, again, I use various appliances to expand the palate, but when the kid's young, it's easy to do. But because I learned that tongue positioning was important from my oral myology team, I tend to use expanders that didn't prohibit tongue position. Face masks, this is Dr. Grumman's good friend of mine, fantastic orthodontist, passionate about early interceptive treatment. I used his face mask because I didn't want any backward rotation, particularly in these children that already had a long face. The other face mask that I use is from Dr. Sandra, and this face mask uses the sternum for anchorage and the forehead. And you can see this girl, no braces, just expansion, reversible face mask. Look at her face. Can you see the improvement in the mid-face development? That's also an improvement in the airway. Now, not all the kids needed class 2 correction, but those who, after I got the maxilla in the right position, didn't have that natural growth and still had quite a class 2 malocclusion, I used, again, a Mara appliance because I didn't want anything in the way of the tongue. So my expansion didn't encroach the tongue. My translation didn't encroach the tongue. So it's just my sort of preservation of oral volume kind of philosophy. And then we used a Maya brace as our retainer. And again, there's various types of Maya braces for the class 2s or the class 3s. And with the Maya brace, my myofunctional therapies were using some of their lip trainers. And I'd really like you to have a look at that. I think this is where orthodontics meets myofunctional therapy really well. Now, for consistency of care, I tried to get these children to see the same myofunctional therapist, but that wasn't always possible. I tried to get these children to see the same ear, nose, and throat doctor. That wasn't possible. But one thing that was standardized is that their treatment was done within full face orthodontics. So the orthodontics didn't vary. But the majority of the people who were doing the myofunctional therapy were trained by Joy Mueller, who's an amazing myofunctional therapist in California. And if you want to learn more about myofunctional therapy, I highly recommend go to her website. She works a lot with general dentists and orthodontists in this sphere. Right? Now, I said that I would do a 1-hour lecture, so it's an hour now. I thank you for the opportunity for allowing me to speak as a tribute to Pablo. I will end today's presentation by putting up this slide, which is my email, info@mahony.com. If you'd like any further information on any of those studies I presented, and watch this space because I'll be publishing more in the literature. In Journal of Clinical Medicine, I just had a paper published where I looked at 50 people who had sleep apnea, 50 who didn't. I measured palatal height and vault. And obviously, there was a great correlation that the higher the vault, the higher the apnea scores. You know, things that we take for granted and make common sense, but actually haven't been researched. But my future papers will very much be looking at what treatment modalities gave the best outcome. And I think that would be, but the purpose of this lecture is not what treatment to offer, but really please diagnose the problem. Look at your kids in a different light. Don't just look at their dental crowding. I think airway first, dental crowding last. And with that, I thank everyone for their attention. Bye for now.